Points here. Over to you, Ebethstha.
Good morning. I'll be representing Medicine 2. The topic for my presentation is the purple brainstorm. I would like to start with a spotter. Any comments on this?
Yeah, shall we start here?
Purpura. So purpura fulminans. Purpura fulminans. Animal more than 1 centimeter. Rice lesion. Rice lesion.
So it's important to keep practicing, just like how Dr. Sudhya was explaining. You describe a lesion with all the characteristics visually and symptom-wise, and then come to a potential list of syndromes.
Okay, so I'll start with the history. She's a 48-year-old lady who had presented with fever for 15 days, high-grade intermittent fever, headache for 12 days, which was holocranial intermittent in nature. She also developed rashes 2 days prior to her presentation to us with violaceous patches over her arm, body, and trunk, and altered sensorium for 1 day. Apart from that, there was no significant travel history, no significant comorbidities, personal history, or family history. On examination, she was conscious but disoriented to time, place, and person. Initially, her pulse rate was 100 and eventually she became tachycardic. Blood pressure was normal at the time of presentation, but she went into shock requiring noradrenaline. Respiratory rate, she eventually became tachypneic and went into hypoxia requiring oxygen with a temperature of 101. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema was present. So, coming to the cutaneous examination, these are the lesions which are present predominantly over her upper limb and lower limb and also over the trunk. These were multiple dark purpuric macules and patches arranged in a reticular pattern on the trunk and extremities with the back being spared. Few purpuric macules were present even on the upper eyelids and malar region. Otherwise, scalp, palms and soles, nails and oral mucosa was normal. So when we see a presentation like this, normally we can get confused with livido reticularis. So livido reticularis is a blanching rash, and the pathophysiology behind livido reticularis is there is a decrease in the flow of blood in the blood vessels, which eventually leads to formation of livido reticularis. Whereas retiform purpura is a non-blanchable rash, and it happens because of occlusion in the blood vessels. On systemic examination, cardiovascular system was normal. Respiratory system, bilateral crepitations were present in bilateral infrascapular and intraaxillary region. Abdomen examination was normal. Central nervous system, she presented with severe photophobia. Terminal neck stiffness was present. Apart from that, deep tendon reflexes and power was within normal limits. So clinically, she's a 48-year-old lady from Kolar who presented with a short febrile illness for around 2 weeks with extensive retiform purpura, probably a purpura fulminans because of the extensive involvement with symptoms of meningoencephalitis with ARDS and went into shock eventually. So, based on our clinical history examination, these are the differentials which we considered. We thought of infectious etiology like a rickettsial infection presenting with shock, ARDS, and meningoencephalitis. Second, we also thought of a meningococcemia with meningoencephalitis, ARDS, and shock. We also thought of viral hemorrhagic fever, sepsis with DIC. Going into systemic vasculitis like a small vessel vasculitis, autoimmune involvement like a SLE flare with CNS lupus, pneumonitis, and a vasculitic rash with shock, and others which we thought of were a TTP. The relevant investigations are as presented. She presented with thrombocytopenia of platelets around 23,000, mild elevation of enzymes, renal parameters were normal, serum electrolytes were normal, blood-borne viruses were normal, and peripheral schistocytes was negative. On CSF examination, WBC was mildly elevated with proteinuria. Otherwise, all other cultures were negative. So based on the differentials, we evaluated her and her autoimmune workup was negative. Vasculitis workup was also negative. Cryoglobulins were not detected. Coming to the infectious etiology, dengue, scrub, chikungunya, malaria, spotted fever, Vidal were negative, but wheel flix came as OX2 positive. OX90 and OXK was negative. Apart from that, we also did an imaging on her. CT, neck, thorax, abdomen, and pelvis suggested features of ARDS. Brain imaging, we have a verbal report which says no significant abnormality. And then because of the presence of cutaneous lesions, we went ahead and did a skin biopsy. So skin biopsy showed the final impression was a coagulopathic changes with fibrin thrombi and which with a purpura fulminans as a possible histological diagnosis. So final diagnosis based on a history examination investigations is a probable rickettsial infection with the retiform purpura, likely a purpura fulminans because of the extensive involvement with ARDS, septic shock, and aseptic meningoencephalitis. So I just like to talk a little bit about retiform purpura. So retiform purpura are basically non-blanchable purpura. These are persistent dark red to dark purple hemorrhagic patches or plaques that occur on the skin, and they have a characteristic reticular angled branched configuration. So when this retiform purpura becomes extensive, we call it purpura fulminans, which is a life-threatening condition. They develop as a consequence of complete vascular occlusion and vascular damage involving blood vessels in the skin. So there are multiple causes and etiologies for purpura fulminans or retiform purpura. Some of them can occur because of thrombosis or coagulopathy, as seen in DIC, APLA, protein C proteinase deficiency, drug-induced like warfarin-induced necrosis or heparin-induced thrombocytopenia. It can also be embolic, as seen in cholesterol embolic, septic embolic, and atrial myxoma. Intravascular protein deposition, as seen in cryoglobulinemia and the others, vasculitis, opportunistic infections, and there are other causes like severe renal failure causing calciphylaxis, primary hyperoxaluria, and infections like pyoderma gangrenosum also. So when a patient presents with skin lesions like this, one of the life-threatening conditions, one of the differential that has to be considered is also a DIC. So findings that should allow proper prompt investigation includes having a purpura fulminans, or when they develop signs or symptoms of sepsis or shock, or they develop other signs of severe illness like fever, organ failure, or altered mental status, or acute development of retiform purpura in an immunocompromised patient. When a patient presents like this, it is we have to go clinically based on history, following with physical examination and skin biopsy, and based on the differential going with the underlying lab parameters. So our patient was initially treated with IV antibiotics. During the course of treatment, as I had mentioned before, she went into septic shock, necessitating the need for NORAD, and she had to be transferred to ICU for ventilator assistance. Subsequently, her condition stabilized and she was shifted back to the ward. Her fever was resolved, but they would not want to continue treatment, and hence she was discharged on request. So the learning points from my presentation is how to approach reticular purpura and to recognize life-threatening emergencies when a patient presents with the following skin lesions. Thank you.
Thanks a lot. Any questions or comments? Could you? What serology? Spotted fevers, but one of your serology was positive, which was?
That was wheel Felix. OX2 was positive, but spotted fever at covers negative. But
So what could be the particular etiologies for this?
mostly OX2 positivity is seen in spotted fevers.
You get a lot more of these rashes, organ system involvements, which are much sicker compared to your scrub typhus. Okay, so when you ask them history of having gone to the, polar, I don't need to ask them this to exposure history. We had one of our staff who went trekking into the Watanjatman Hills because he was doing some medical camps for the poor patients, came back with multiple tick bites and actually had spotted fever. So always check for when they come in early, ask for that history. There's another patient that came in who was painting the Chittur, that this thing, and they were clearing vegetation after the rain. So get that history. because it gives those connections in your head to say, this happens, then this is what we are thinking.
Ma'am said spot fever do present with purpura fulminans, especially they have these rash in the palms and soles that is very pathognomic. I think there's an manuscript published from CMC where we have a case series of patients with spotted fever and purpura fulminans. And especially it's more common in the Karnataka, the Kolar, Bangalore belt than what we actually see in Tamil Nadu and Andhra. Andhra, they do have some spotted fever, but it's more common in we don't have any deaths in spotted. Very rarely do have we do have deaths in spotted fever, though they present sicker with purpura fulminans, but just with doxycycline or azithromycin in pregnant women, they do improve very well. So doxy is the, picking up the syndrome is the clue, and starting early appropriate antibiotics will really help in decreasing the morbidity and the mortality.
The minute you get a very short wave, fever, high fever followed by rash, same next symptoms, monthly onset, meningitis. And that requires, again, going back to say, if you all are exposed and make sure that all of you are exposed, also make sure that. So that's
Goes to Osborne, mainly because he loaded his presentation well on time. That's a reminder to the others, but his slides were good. He approached it very well. Another reminder to the PGs, focus on one or maximum two topics that you can cover. The input from faculty on these subtle aspects of how you think is very important. So we have too much to cover in your presentation. We don't get that. Thank you.